This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from World Neurosurgery, published in 2026, titled Microsurgical and Endoscopic Characterization of the Anteroinferior Wall of the Cavernous Sinus, a cadaveric study at the intersection of anatomical fossa.
This is a topic that hits home for those of us spending long hours at the skull base. Traditionally, when we teach residents about the cavernous sinus, or the CS, we talk about it as a five-walled structure. Ilara, do you want to refresh our listeners on that classic model?
Of course. Classically, the cavernous sinus is described as having a roof, a posterior wall, a medial wall, a lateral wall, and an anterior wall. It's a very geometric, box-like way of thinking that has served us well for standard approaches.
Right. But as our techniques have evolved, that box has started to feel a bit simplified. This paper argues that as we move toward more inferolaterally expanded trans-cavernous approaches, that traditional five-wall description starts to fall short. Specifically, there is a transition zone that hasn't been adequately defined until now.
Exactly. The researchers focused their characterization on what they are calling the anterior-inferior wall of the cavernous sinus. They used a combination of microsurgical and endoscopic cadaveric dissections to look at the area where the anterior wall, the AWCS, meets the lateral wall, or the LWCS.
And this isn't just a minor corner of the sinus. The study describes this area as sitting right at a major anatomical crossroads. According to the paper, this anterior-inferior wall is located at the intersection of three distinct anatomical fossa. Ilara, can you walk us through those?
It's a complex neighborhood. You have the middle cranial fossa, the superior orbital fissure, the SOF, and the pterygopalatine fossa, or PPF. The study emphasizes that this specific region acts as a transition zone between these three spaces.
This is crucial for the practicing neurosurgeon because when we are performing expanded approaches, we are often working precisely at that intersection. If the anatomy of that transition zone between the anterior and lateral walls is inadequately defined, as the author suggests, the risk to the patient increases. We need to know exactly what we are looking at when we transition from the middle fossa into the SOF or down toward the pterygopalatine fossa.
Precisely. The study's goal was to provide a microsurgical and endoscopic characterization to fill that gap. By using both perspectives, they've been able to map how the fibers and the dural layer shift as you move inferolaterally. It's about understanding the nuances of the anterior-inferior wall, rather than just treating the CS as a collection of flat surfaces.
I think it's interesting that they highlight inferolaterally expanded trans-cavernous approaches. For a long time, we were more focused on the superior or purely lateral corridors. But as we push the boundaries of what can be done endoscopically or through combined approaches, that inferolateral corner becomes the front line of the surgery.
And that's why this cadaveric data is so valuable for residents and fellows. When you're in the lab, you can see that the transition isn't always a sharp 90-degree angle. It's a characterization of a zone. The study helps define the boundaries where the anterior wall ends and the lateral wall begins, especially as they relate to the structures exiting the superior orbital fissure.
It really highlights the importance of the intersection between the cavernous sinus and the pterygopalatine fossa. That's often a no man's land in traditional textbooks.
It is. And by characterizing the anterior-inferior wall specifically, the authors are giving us a more accurate roadmap for navigating the complexities of the skull base. They are moving us away from that simple five-wall model and into a more three-dimensional, clinically relevant understanding of the CS.
It's a great reminder that even with structures as well studied as the cavernous sinus, there is always more to learn when you change your perspective, whether that's moving from the microscope to the endoscope or simply looking at the intersection instead of the wall.
Well said. For our listeners who want to dive deeper into the specific measurements and the photographic evidence from the dissections, we highly recommend checking out the full study in World Neurosurgery.
That's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you in the next episode.